আচ্ছা। No, today we had some great presentations. I was watching from the top. Some wonderful presentations were happening here. We have seen some very, very interesting and advanced techniques. And in fact, I was very scared when I was coming down, and especially when I saw recent developments are written over here. And my topic is cutting seton in the era of sphincter sparing surgery. Good evening and assalamu alaikum. I'm Dr. Asif Al-Masaq. So I don't have any disclosures. This is where I work. Now I'll start with a story. A young doctor came to us with his father who had recurrent complex fistula with abscess. He had done 3 surgeries without any success, and all the 3 surgeries were sphincter sparing surgeries. And at the end of the day, they came to us for their remedy, so we decided on doing a staged cutting seton procedure for this patient. So this is what it looks like. Looks quite ugly. If I agree with everyone, looks very ugly and very scary. And the question the doctor actually who was inside the operation theater, he had 2 things to say. Number 1, that's it, and number 2, Asif bhai, is it going to heal? So actually, we were very fortunate with that patient, and it did heal quite well with quite a nice scar. And this gentleman really had no incontinence, but occasionally he's a very pious person. He said he had some difficulty in controlling his flatus. So by now, if you're wondering where my position is, I'll tell you upfront that I am a big supporter of cutting seton for complex fistula surgery. And I'm sorry if I'm sure many of you will disagree with me, but still till today I am a big fan of this surgery because this is time tested and this is a surgery that I know it works. So what is cutting seton? Now I asked our old friend DeepSeek. If you don't know what DeepSeek is, it's an AI. What cutting seton is? So it is a thread-like material used particularly for complex or high fistulas that involve a significant portion of the anal sphincter. It is used to gradually cut through the sphincter muscle while promoting fibrosis and prevent incontinence. So this is a very nice video which shows exactly how cutting seton works. It does not allow the dislodgement of the sphincters. So why do I like it? Number 1, it's very easy to learn, it is inexpensive, and arguably it's probably the most successful techniques for complex fistula. Again, what are the downsides? It's very painful, multiple visits are necessary, it creates a very large defect as we have seen, it requires dressing for a very long period of time, and wound healing takes a very, very long time. And of course, the last but not the least and the biggest thing that's our concern, that is incontinence. So I'm sorry if some of you are thinking that today we'll be discussing about some tips or tricks about cutting seton, because there isn't any tips or tricks. It is very, very simple. First, do a very good digital rectal examination, find out where the internal opening is and how much of the sphincter has been involved. Do an MRI if necessary. Endorectal ultrasound is also helpful. Then do a paraoperative test, and then you may use a probe if you want to. Remember never to do this, never create another tract once you are trying to use the probe. So this is the end result. We use cutting seton for high transsphincteric fistulas and suprasphincteric fistulas. Always remember, must have a very, very good finger, because this is $1 million finger, and if you do a mistake over here, then the patient may be in trouble, or maybe you'll be in trouble. In this case, we thought it's a fistula, but paraoperatively we found out that this is actually a pilonidal sinus. So what are the treatment strategies? Now our favorite book, the BSCRS textbook of colon and rectal surgery, it gives us 3 main goals. Number 1, control of sepsis. Now we have no confusion about that, absolutely correct. But I have slight disagreement with the second and the third terms, which says definitive repair of the fistula. Now I don't think we ever do a definitive repair of fistula. and maintenance of incontinence. Now, I think this would be a more appropriate way of writing it. The treatment strategies are: number one, control the fistula, eradication of the fistula tract, but whatever means you want. And number three, the most important, maintenance of an acceptable level of continence, because we'll be discussing shortly about this. Now, what is an acceptable level of continence in context of fistula surgery? Now, what are the different types of incontinence? Incontinence to solids, liquids, gases. Some has to wear pads, some has to do a major lifestyle alterations. So, I had this chart. I took 100 patients and asked them what is unacceptable to them, and this is what I called an unacceptable chart. Now, if you see, almost 100% of the patient, what is unacceptable? Solid stool incontinence, absolutely unacceptable. Recurrence, absolutely unacceptable. So, from a surgeon's point of view, recurrence is not an option for you. Liquid stool incontinence, now here the patients may be slightly flexible. If you have to wear pads for that or lifestyle alteration is necessary, they will not agree with you. But if there's slight mucus incontinence, they might agree with you only if you can provide them with the promise that you will cure their fistula. Again, gas incontinence may be acceptable. And these 8 people, I don't know what their problem is, but any and everything is unacceptable to them, so these guys don't deserve surgery. So we did a research, one of our friends abroad did a research, and this is a systematic review. It was done on 2023, and they found out that the patient had 6% recurrence. The patient who used cutting seton, they had 6% recurrence, and 16% risk of incontinence at 6 months. So what happens if we compare this with a sphincter sparing surgery like lift? This research was done on 2022 and published in 2023. Now they said the success rate is 51% initially, then after dressing and other procedure the success rate is 71%. I think that is acceptable. Now, many of you are thinking that probably this lift never causes any fecal incontinence, but to your surprise, it does cause incontinence. And if you look at this research, this was published in British Journal of Surgery on 2024, and they said, if you look at this, although the immediate impact on postoperative continence appears minimal, long-term incontinence rates are concerning. Now, if you look at this is a Sankey diagram. If you see the number 1, people were normal, but 11 patients had severe incontinence after lift surgery. So what is my experience? I did some research myself. I did a research on 100 patients, and let me show you, because time is short, so I have to finish it. So usually the mean number of seton ties that I did was 3 times. It takes around 21 days. Healing time usually 3 to 4 months, and I did a follow-up of 6 months. So I had a recurrence found in 3 patients in 6 months. 21 patients were noted for incontinence. 17 patients had gas incontinence. Liquid incontinence was 4 patients, but very, very fortunately, none of them had pads or major lifestyle modification was necessary. There was no incidence. That's very fortunate for me. No incidence of solid stool incontinence. So my experience, this is very important. Please have a look at this. Patients are very reasonable. Most patients are willing to accept flatus and even liquid stool incontinence or mucus incontinence without pads if you can promise to cure the fistula. This is very, very important. You must be able to cure the fistula. Then they are able to accept it. And as I can say, I always prefer seton. So there's a good chance that some of you or most of you will not agree with me. In this case, the take-home message for you is recurrence is never acceptable. And remember, any surgery, outcome of the surgery must not be more distressing than the disease itself. So I always had difficulty with complex fistulas like this, and a song always comes to my mind. সোজা পথের ধাঁধায় আমি অনেক ঘুরেছি, পথ হারাবো বলেই এবার পথে নেমেছি. Thank you very much.